Do we wait like for 5 minutes to just post it in the group? Did you study? Sasavera? Which you felt some parts are difficult for you? Abhi Jappandi, I'll tell you. Which you can just read, you can just read it. Because see, honestly, like 10 days or 20 days before the exam, chadvachu because it's theory gaga, but konchamana basics teliyaga, you need to know. Then you can easily write exam. Even if you don't like mention it, you take the Atlandara. Okay. In the future, don't miss any classes. ఎంత నచ్చకపోయినా take I'm not talking about me, but your main classes which you have in nursing. ఏది మిస్ చేయొద్దు. It will go above your head, but do time pass in the class. We used to play Candy Crush in our class, but we used to attend classes just for the heck of it. Yeah. Hi all. So I'm back. So let's start with today. A very good evening to all of you. Thank you so much for joining me. Just online, somebody just let me know whether it's clear to you all, whether my voice is audible, the slides are clear. Just let me know, please. Okay, so let's start. So we stopped here last time. So we'll start with amputation today. What is amputation? It's like cutting off a part of your body. It could be limbs, it could be any part of your body. It's called amputation. Amputation of the lower extremity. How do you do it? At what levels do you do it? Is what we're going to learn now. Firstly, removal of a limb or a part of limb is known as amputation. Complications, what can the complications be? Once you're amputating a part of your body, bleeding can occur from that site because major arteries are involved, veins are involved. Okay, like there could be infection because sometimes in some amputations, the wound is kept open, or if you're suturing it and the patient ends up being a diabetic, so they are more prone to infections. Then you have something called ghost pain, which is one of the most common complications. It is called phantom limb pain. What do you mean by it? Even though the part of that body is missing, but still at times during stress or sometimes, or the patient feels as if physically the part is missing, but mentally the brain feels that the part is still there. And something you end up going and hitting a object or something, even though the limb is not present, sometimes the brain thinks that maybe this part is present. It has something is happening to the limb, or it is on fire. That kind of a feeling, and then the patient will come saying that I have an intense pain in that part. It sounds very weird because that part is missing, and how can you have a pain when the part is not a part of your body at all? That's called phantom limb pain. Okay, you especially see this in cases in like army officials or people who are involved in wars where they lose a part of their limb, and firstly they have PTSD is nothing but post traumatic stress disorder. Along with that, they can also have this phantom limb pain. It's also called as ghost pain. Then you have flexion contraction. So if you're doing it a little below the joint, a little above, all those flexor muscles, they go into contraction because of misuse or disuse of the muscle. So that can happen. Next, that's why whenever you undergo an operation, especially amputation, we ask the patient to keep the limb as straight as possible. Okay, to avoid this flexion contracture. Next, what is phantom limb pain? Like I explained just now, pain experienced by the patient following amputation from the part of the limb that is no longer existing. It's not present, but still the patient says, I have pain in that. Suppose the patient is missing below knee on the left side, okay? Below knee, he has lost his leg. But he says, I have pain in my left leg, when the part is itself not there. That is called phantom limb pain or ghost pain. The pain experienced is real because the brain is thinking that, okay, this part is there and there is pain happening. What is the management for pain? You'll give painkillers. You have to give, even though the part is not there, but the patient is pursuing pain, and that pain is actually real. What is nursing management here? Prone position may be recommended for following an amputation. So you make the patient sleep on prone. Prone means what? You're making him sleep on his tummy. If you're sleeping on your back, it is supine. If you're sleeping on your tummy, it is called prone position. Stump is what? Which is left. Leftover part of that limb is called stump. Stump should not be elevated on a pillow, because if you elevate it, what happens? All that flexure muscles become contracted and they end up into flexion contraction. So you recommend them to keep it flat as possible. Okay. Then the foot, if recommended, the foot end be elevated, but not the stump. Okay. Above knee amputation, that is amputation you're doing which is above the knee, prevent the external rotation of the stump by placing a sandbag. So just on the lateral side of your thigh, you will place a sandbag to prevent the lateral rotation of the above knee amputated stump. Okay? Next, below knee amputation, don't prolong sitting, hanging the stump while sitting. Suppose if the patient has lost just a part, half of his leg, the foot and half of the leg is missing. So it's a below knee amputation. What you will think that, okay, the patient can sit for a long time, prolonged sitting, this is all should be avoided. The nurses should tell the patient not to sit for a long time. Also tell the patient not to hang his stump for a long time, because that can lead to stasis, and stasis can lead to infections. We don't want it. Next, reinforce surgical dry and elastic compression. So you have to keep whatever compression is there, it has to be dry. Dressing which shrink the stump, reduce edema, and prepare the stump for prosthesis. So what you're doing at the end of that stump, that whatever the remaining part of that limb is there, which we have it, at that end, it is supposed to go and sit into a prosthesis. So this part has to become a little bit shrunken. For that, you use a dry dressing or an elastic compression. Firstly, it is to reduce the edema. Second, it is to prepare the stump for the prosthesis. Prosthesis is nothing but artificial limb, which you're going to attach to that stump. This is above knee. As you can see here in the picture, you can see a skin incision very clearly. Okay, knee joint is damaged, so you're completely removing it. And here, can you see orange? I don't think so yet. Here you can see clearly. Okay? This is the stump part where you've operated and all that edema is being reduced because of a dry dressing. This is a jiggly saw which you don't have to know, but this is used to cut the bone. Okay? Here you can see this red color line here is the skin incision given, and here the knee is damaged. You're completely removing of this part. That was above knee, and you're trying to shrunk this part with the dry dressing so that this goes and fits into this gray color prosthesis. This is below knee. As you can clearly see, the knee joint is very much there, and you're amputated just below the knee here, and you're allowing this stump to heal and shrink so that it goes and fits into this prosthesis. Can you see damage here? This is called tubercular spondylitis. I'll not explain this. Once we come to that particular thing, I'll let you know what it is. Next, we have carpal tunnel syndrome. Carpal tunnel is nothing but this area. Okay, this area is where carpal tunnel can occur, and the patient is unable to extend or flex. It causes extreme pain, and you have a retinaculum here. Retinaculum is a set of tissues. Okay, it's like a fibrous band like thing below which the median nerve goes and supplies the thumb, the index finger, the middle finger, and a little half part of the ring finger. That is all supplied by your median nerve. So if this gets compressed, na, this area can develop loss of sensation because the nerve is getting compressed. Median nerve goes here. That's called carpal tunnel syndrome. Compression of the median nerve causes this condition. Whenever you have a thick elastic kind of band, imagine when we put a pony. If you put it too tight, what happens? Just all your hair is all like tight, na? That kind of compression occurs here also. Whenever there is edema occurring in that compartment or any kind of issue, or misuse of that area, keeping it like this for a long time, keeping it like that, misusing your wrist for a long time can cause a compression because it is lying just below the retinaculum. Pain, numbness, paresthesias, and weakness over the thumb, index, and middle fingers are the manifestations of carpal tunnel syndrome because that is all supplied by median nerve. Why pain? Because the nerve is involved. Definitely, you'll have pain. More worsening, you can develop paresthesia. Paresthesia, like tingling like sensations occurring. Okay, you'll have this chima, they'll say, no? Chima laga anpistundi. I feel like ants are crawling on my hand, that kind of a feeling. You'll have weakness because the nerve is getting damaged. At the end, you'll have numbness. You'll completely lose. It can go into paralysis. Here, you can see this is thenar eminence. So this part is also supplied by median nerve. So because median nerve is getting compressed here, this area में यहाँ से नीचे से आता है, okay, median nerve is getting compressed here. Even this muscle is going into atrophy because the nerve is getting damaged. That's one of the muscles being supplied by median nerve. You can see it is supposed to be nice, bumpy, nice. It's supposed to be like round, but it is losing its texture and the muscle disuse or the paralysis leading to atrophy of the muscle. And you can see here. Okay. So this is the blue area. All this blue area is being supplied by the median nerve. That's where the numbness develops. This is this band-like thing you can see. This is flexor retinaculum. Below this, the nerve is going. So यहाँ पे you're developing pressure inside this compartment. That is called carpal tunnel syndrome. See here पे because of the compression, this median nerve here in this compartment gets compressed, leading to numbness in that area. It's going below the transverse carpal ligament. This area has carpals, no? Next, C5, C6 and C6-7 are the most common sites for cervical vertebral prolapse. In cervical areas, you have C7, C1 to C7. In that, you have C5, C6 and C6, C7. Between these two, the disc can end up into prolapse. These are the commonest sites in the cervical region. That's why many of them develop this spondylitis kind of issue, in that area itself. Next, if you go into the most commonest sites are in the lumbar region. What are the sites? L4, L5, L5, S1. These are the commonest sites in the lumbar region. So just remember these two things. Cervical is also very common for disc prolapse. Lumbar more than cervical. But if you see only cervical, in cervical, these two areas, C5, C6, C6, C7, are most common sites for the prolapse. But if you take only lumbar, again lumbar mein it is L4, L5 and L5, S1. Next. Yesterday, last class I have told you what happens with disc prolapse. Annulus gets the annulus becomes weak and the nucleus in the between herniates, as you can see here. 1 second. Thank you. I just saw somebody said it's very clear. Thank you so much. It's just like hardly 30 slides left. Once we do this now, we're almost finishing 200 pages. So after that, we'll shift into the new slides. So we were here. The speed is okay, right? Alikya? అర్థమవుతుంది కదా? Okay, so this part. This is all the annulus outside, which you can see like concentric circles. Those are the annulus. This is becoming loose, and this beach may, which is their nucleus, it is coming and herniating outside, which is compressing on the nerve here. Okay, leading to other issues. Whichever area this nerve supplies, that area gets affected. This is a disc prolapse. As you can see here, this is normal here. You can see now, this is normal disc. This is the annulus and this is the nucleus inside. So this has to be within this disc space only. But यहाँ पे क्या हो रहा है that annulus is completely gone and all this nucleus is getting herniating outside of the compartment and it's going and compressing the spinal cord here, as you can clearly see in this MRI. What is bariatric surgery? I'm very sure many of you know what it is, just basic sense. What do? They just remove a part of the stomach so that it helps in losing weight, especially in extremely obese patients. This surgery is being done so that the food immediately enters into the intestine. It skips a part of your intestine. You know, stomach, if it is staying, stomach is like full completely. The food stays there for a long time, more absorption occurs, more fats are absorbed, but you don't want it. You want to come, you want the food to enter and quickly exit, so that lot of fatty absorption doesn't take place. And usually these patients tend to eat very less. They eat frequent meals తీసుకుంటారు, but they tend to eat less because they can't stomach it in. ఎందుకంటే that part of the stomach, the part is removed completely, so the food can't stay. There's no space there for the food. Okay, it is a surgery performed to reduce gastric capacity and thereby it helps in weight loss among clients with morbid obesity. Morbid is like more than 40 BMI. Okay, so you that can cause varied other issues. So what you're trying to do is you're helping a patient to lose weight by doing this surgery. We don't recommend it for everybody, but it's meant for morbid obesity patients only. That too, there are specific cases in it. If those obese patients undergo these kind of surgeries, sometimes what happens is death can occur very easily because they're way too obese. Okay, usually when they're extremely obese, we don't recommend operations. They have to lose some weight. Two types of surgeries are there here. One thing is called gastric restrictive surgery. It's in the name. You're restricting the stomach. Vertical banded gastroplasty or circumgastric banding. Circum means round. Gastric banding. You're banding the stomach. You're reducing its cavity. Okay? That is second thing. First thing is gastroplasty. You're removing a part of the stomach. Vertical banded gastro. Vertical means like this. Circum means round. Either you're doing a vertical banding or you're doing a circumbanding. Simple. This allows normal digestion without any risk for nutritional deficiency. What happens is just part of it you're removing, but the remaining part is still there where the normal absorption takes care. Why are we doing it? This is to prevent the nutritional deficiency. Next, gastric restriction combined with malabsorption. What happens is you're doing a gastric restrictive surgery here, but the absorption is not happening properly. That can lead into malabsorption. Yeah, where it happens, especially when the stomach is stapled to reduce the capacity. You're stapling the stomach completely. You're getting this side of the stomach and this side of the stomach and stapling it in between. You're reducing. That can lead into malabsorption. Stomach is stapled to reduce the capacity. Duodenum and a portion of ileum are bypassed to reduce the calories absorbed. So what are you doing? यहाँ पे duodenum. So okay, we'll come to a picture and I'll show you. So let's just imagine this is your esophagus. Okay, it's coming. This is your stomach. This is your pyloric region. यहाँ पे it is entering into duodenum. Right, duodenum. And then into ileum. These two are bypassed. So directly this enters, this bypasses duodenum, this bypasses ileum. Directly it enters into the jejunum or the large intestine. You're bypassing this areas. Bypass ante hindi. Everybody goes by bus. Na? You know what bypass means. You're crossing over that particular part of that city. You're not entering into it. You're going outside of it. That is called bypassing. Same thing is happening here. But what can happen here is, whenever you do that kind of a thing, most of the absorption, especially B12, absorption takes place in ileum. Okay, so bypassing that ileum, what happens if you bypass? B12 absorption doesn't take place properly. They will enter into B12 deficiency. That is called one of the malabsorption syndromes, which can occur in this kind of stapling of the stomach and bypassing the major intestines. They will reduce weight, but they will also have vitamin deficiencies, which we don't want. Next, dietary education to the clients following a pediatric surgery. Now they have underwent a pediatric surgery. What kind of dietary education will you give to the patient? You have to avoid food high in protein, fat, and sugar. So all those things which can increase your body mass index, you're asking them to reduce that. So they have to eat slowly. They have to chew well, because you have removed a part of the body, na, where acid production takes place. Food stays there for a long time. It is broken down into simpler products. Because you're removing a part of it, who is supposed to do more work here? Your mouth is supposed to do more work. You have to make the food easily absorbable, easily digestible. So metta mettaga tinala, like mudda, you know, like how you feed small kids. You have to eat very soft food, take more of liquids, and you have to, even if you're taking normal chapati or if you're taking some kind of vegetable, you have to chew it well into your mouth. You just can't keep swallowing it. Okay, take nutritional supplements, because bariatric surgery sometimes can lead into malabsorption. Definitely absorption, you're reducing the time for absorption. So whatever absorption, good absorption has to take place also is reduced along with bad. So they will enter into vitamin deficiency. So you're supposed to give them supplements. What kind of supplements you'll give? Calcium is there, iron is there, multivitamin, B12. So यहाँ पे you can see that actually this is the complete stomach. What are you doing? You're removing of this particular part of the stomach. This is the excised stomach. And this is the gastric sleeve, which is still remaining. And this is the pylorus. It's entering into duodenum. This much part of the stomach is being removed. This is also done in bariatric surgery. So, firstly, I told you vertical banded gastroplasty. Plasty is what are you doing here? यहाँ पे vertically you're removing a part of the stomach. Next, laparoscopic adjustable gastric band. Adjustable बोले तो you can adjust it, and it is done laparoscopically. Then you have RU-NY, gastrojejunal bypass. So you're bypassing that part of the intestine. This is called sleeve gastrectomy. I will not go into details. This is way too much into details for you all. Illustration of duodenal switch. So what is happening is, यहाँ पे that part of stomach is supposed to be there, na? This is removed. This is the gastric pouch or the gastric sleeve, which is still remaining. You can see here, na, stitch marks. This part of the stomach is completely removed, and this part is remaining. That part, you're not allowing it to open into the duodenum. You're directly bypassing it, and you're putting it into the elementary limb, okay? Or you can say the remaining part, like यहाँ पे you're crossing over duodenum and ileum. You're not allowing the stomach, the remaining part of the stomach, to open into the duodenum. What does the stomach open to duodenum, right? First part of duodenum. You're not allowing that. You can see this is open here. यहाँ पे you're suturing of this part, directly opening into an elementary limb, which directly goes and opens into the large intestine. You're actually bypassing all this. All this area is being bypassed. So food is not entering like this. It's supposed to go like that, like that, like that, and come here till cecum and enter into the large intestine. But यहाँ पे what you're doing, directly you're connecting it into a very small portion, leftover portion of the jejunum or the ileum, last portion. And then directly this is opening into the large intestine. You're reducing the absorption area of the food. This is called sleeve gastrectomy. Ectomy means removal. Remember that. Also, what you're doing here is biliopancreatic diversion. Whatever that bile or the pancreas duct is there, na, it opens into duodenum. That also you're diverting, because that is required for absorption. Then you have something called, okay, we're coming back to disc prolapse again. What is nursing management? What are you supposed to tell the patient to do here? एक तो bed rest, which everybody knows. Whenever you have a disc prolapse, you will tell the patient to take bed rest, because if he keeps moving a lot, now firstly, the patient is in extreme pain. Secondly, if he puts a lot of pressure on that area, that particular nerve on which this disc is getting prolapsed, now more pressure can happen and the nerve can end up into damage, and that patient can have a particular issue. Suppose if it's involving the limbs, then the patient can have paralysis in the limbs. We don't want that. You have to maintain head and spine in alignment. Head shouldn't be like this, spine shouldn't be forward, everything is supposed to be straight. So when does it happen? When you're sleeping supine, okay, when you're asking the patient to take rest. Second, avoid sitting for a long time. Just like amputation, yahan pe bhi you're asking the patient to take rest supine, like on the bed. Ask him not to sit for a long time. Again, if you sit, what happens? Compression can occur more severely. That is one thing. Avoid flexion, avoid extension and rotation of the joint, because you're trying to reduce the edema near the nerve. You don't want the nerve to get compromised. So you're not allowing a lot of movements. Whenever you have fracture, what do? You tell the patient not to move the limb or rod. Automatically, first of all, whenever they're in pain, they will not move that area. Whenever you don't move that area, na, that irritation reduces, the inflammation reduces. All things once they reduce, na, if there are major vessels and nerves going into that area, that can be saved. Okay. But if you are causing more disturbance there, edema increases. If there is some kind of an injury to the artery or the veins, blood can occur. That can cause compression on the nerve, which can lead to paralysis. That is in injuries. But what happens here? Already there's a lot of tension on the nerve, and if the patient keeps moving nicely, lifting weights, doing all the work, he's causing more compression on the nerve. This nerve can get damaged completely. We don't want. Simple. Next, what is cervical collar? What are you doing in spondylitis? You're keeping the angle here in a particular angle. You're not allowing the flexion or the extension of the neck here in the cervical. Whoever has a cervical spondylitis or a disc prolapse here, you'll ask them to wear a collar so that they don't give a lot of movements, jerky movements to the neck. Hence, you're giving rest to the neck. You'll give analgesics because they're in pain. You'll also give anti-inflammatory and sedatives. Sedatives because that pain can be extreme and those people can be irritated. And if they're not cooperating, you have to give them sedatives so that they take more rest. Anti-inflammatory because there's inflammation there. You're giving anti-inflammatory drugs. Exercise regimen to strengthen the muscles. You're doing some kind of exercise. So whenever you have spondylitis, you tell the patient, neck exercises cheyala. Slowly you're supposed to do under observation of a physiotherapist. If we only do at home, we'll do it way too extremely. It can lend into more problems. So don't do that. Next, surgery if conservative treatment fails. All this you do, everything fails. The disc is prolapsing, the nerve is getting involved here. The pain is not reducing. Then you have to do decompression of that area, and that is done surgically. Client is advised to sleep on one side with hip and knee flexed and a pillow between the legs. You have to keep a pillow between the legs, okay? And they're supposed to sleep on one side. This is a cervical collar. If you have a prolapse in that C5, C6, and C6, C7 area, you'll ask them to wear a cervical collar. What is genu valgum? How we people remember is gum. Gum means what? Sticking together. So you have knock knee here. Knock knee means both the knees are coming and getting stuck to each other. Okay. And this happens in rickets. Both knees are touching each other when the leg is straightened. When the patient is trying to stand, or both the knees come and touch each other. That is valgum. Varus. Opposite to that is varum. Varum is bow legs. Both the knees are outside like that. They're bowing their legs. They're not straight. They're bowing their legs like this. Okay. Valgum is both the knees come and sticking to each other. I'll show you. There's a picture. Angular deformity of the proximal tibia. Tibia. Where is tibia? It's in your legs. It's not in your thigh. Thigh bone is femur. Okay. Tibia is down below the knee. Tibia, proximal tibia, there is an angular deformity in which the child appears to be bow-legged. Sometimes it can be a normal finding also in some of the children. It is not always linked with a disease. It can be a normal finding. These bow legs can be a normal finding. But they will have a waddling gait. Their gait will not be normal because their legs are not straight. No? So they'll waddle like that. Have you seen penguin walking? That's called a waddling gait. What is genu recurvatum? Normally, this is how your thigh looks. Imagine you're seeing the patient from the front. This is the front part. Okay, this is how your thigh is supposed to look. This is your knee and this is your leg, and this is, you have your foot here. But what happens is, this is how it will look. So your thigh is like this, your knees are inside, and this is how your legs look. That recurvatum, it's in a curve-like position. I'll show you pictures. Due to the abnormal intrauterine position. So whenever the baby is in the womb, okay, in the uterus, if there is not much of space for the baby to move about, or if the baby is way too overweight for that area, if it is like 4.5 kgs, there's no space to move. It can be in a posture where it is not sitting properly, like it happens in breech. Breech means bums are down or leg is protruding out. In that kind of conditions, this recurvatum can occur. So यहाँ पे what do you see? This is knock knees. You can see na, both the knees are coming and getting knocked. They're knocking each other. This is valgum. As I already told you, GUM, gum. They're sticking together. This is from front view. This is back view. You can see both the knees are coming nearby. This is genu valgum. Genu means knees. So sir has put here, see, gum makes your knees stick together. So both your knees come and get stuck together. This is genu valgum. Rum means there is a rum bottle in between. So there is a bow leg here. Rum makes your knee spread apart. Rum, whenever you're too drunk, how do you walk? How do drunkards walk? They'll walk like that, no? With wide spaced gait. That's what is varum. If you remember gum, the opposite will be rum. That's how you'll remember. Okay. So here you can see in the picture, this is valgum and this is varum. As you can see, there is bowing. There is bowing. Hmm? This is recurvatum. I just told you, how is the limb supposed to be? This limb is supposed to be on this line here. The knees are supposed to be here, but they have gone into a curvature here. This is called recurvatum. 30 high yield points for your exams. First point is osteoporosis. Osteoporosis, I've already taught this in the previous slides. This is just like, fast, quick review. Osteoporosis is the most prevalent bone disease in the world. Fracture of the distal radius, this area. This is your wrist. This is your wrist, okay? The medial part, the part which is facing your body, ulna is there. And the part which is away, this is your lateral part, away from your body is the radius. So यहाँ पे, if there is a radial fracture here in this side, it leads into Colles fracture. Colles fracture is a dinner fork deformity. Dinner fork jo sara, you all use fork na to eat noodles. Have you seen how the fork looks? That's how your wrist will look if you end up having this fracture, which is very common in this area, wrist area. Which bone is getting fractured? Radius is getting fractured. Remember that. That is Colles fracture. Compartment syndrome, I told you. Compartment syndrome is a complication of the fracture, because what happens whenever you have a complicated fracture, all that muscles and also undergo tearing in this area. You have compartments here, in this and your leg area. So if there is a fracture here in these two bones, all that muscles have torn, edema occurs, pressure increases in that compartment. That can lead to compression of that brachial artery, it can compress. It can also compress your nerve. What is the nerve, matlab? There is a, I'll show you. Anterior interosseous artery is which is majorly compressed. Even if you don't remember this, just remember this is the branch of median nerve. Okay, median nerve is getting compromised here in the compartment syndrome. And compartment syndrome, what does it happen? Once the pressure increases, the nerve supply is cut off, the arterial supply is cut off. This area will undergo contracture. This is how the limb will look, and all this area is supposed to look a little bit plump now. It will look more thin because all these muscles will undergo atrophy. That is what is called compartment syndrome. This is one of the examples. It's called Volkmann ischemic contracture. Volkmann, VOLK, Volkmann. Okay. Compartment syndrome is a serious complication. And what is the first symptom of the compartment syndrome is the patient will complain of pain. When does it happen? Even if you're putting a very tight cast, you're not allowing that edema is there, na? It has to reduce. Edema guda undi, on top of it, you put a very tight cast, all that can lead into compression. And if the pressure increases, it will lead into contracture of the muscles. So you have to release this pressure. It's an emergency. You have to do an emergency opening on the sides to release the pressure. Compartment syndrome is a serious complication of casting and splinting. So, if you're putting a very tight cast or tight splint, it can lead into compartment syndrome. It occurs when there is an increased pressure within the confined space, which compromises blood flow, which reduces the tissue perfusion. Next, osteoporosis is what? It is porous bones, and the bones are brittle, easily breakable. It is caused by the deficiency of vitamin D. Remember that. Osteoporosis are brittle bones, which is porous, and it is caused by mostly deficiency of vitamin D. So this is the dinner fork. This is how your dinner fork looks like, no? Imagine you're seeing a fork from the side. You're keeping it down on your plate. Dinner fork, you know what is fork, right? Fork, which you use it to eat noodles. This is called dinner fork deformity. Yahan pe you have a fracture of the radius, okay, that has caused this area to go above like this. It is normally supposed to lie flat like that, na? So this distal part is going above like this. It's leading into a dinner fork deformity, and this is nothing but Colles fracture. Coles or Colles, however you want to pronounce it, Colles fracture. So what you're doing is you're doing a fasciotomy here. Yahan pe in this leg region, there is a compartment syndrome which has occurred. The patient has come to you complaining of pain. You have suspected a compartment syndrome. It's an emergency. You'll open up these areas. How you can see, na, yahan pe, both medial and lateral sides, you'll open. Both on the lateral corners, you'll open. You'll give big slits. Why are you doing it? To release pressure. That's it. Pressure local accumulate aitundi. What are you going to do? You're going to open it off. You release the pressure. Whatever the pressure is happening on the artery and the vein, relieves immediately. This is what you're supposed to do. It's called fasciotomy. What is enema? Everybody knows. So you're cleaning up all the bubble. Okay? It's a preparation done before a major surgical procedure. What do? Either you give a soap water enema, which you supposed to, which was given before. Nowadays, very few setups you use for particular reasons only. Otherwise, normally what you do, you'll give Dalcolax or you'll put a suppository in the patient. You know what is Dalcolax, no? You'll give a laxative so that the patient has complete free motions and the bubble is completely empty of feces. And hot applications are contraindicated. Okay. So you have appendicitis. Obviously, appendicitis unnappudu, why will you give enema? Enema is the emaitadi? Peristalsis will occur. That will end up breaking the appendicitis. Appendicitis has become like a balloon, and if you cause more movement into it, it will burst inside, and that burst appendicitis can lead to peritonitis because once it bursts, all that fecal matter gets spread into your abdominal cavity. They'll just simply come to you in shock completely. That's very extremely dangerous. So whenever the patient comes to you and says he has right-sided pain, and you don't rule out appendicitis, and you think, okay, inko surgery karna hai, let's give laxative, go Venda, you will cause death of that patient. Don't do that. Next, Fowler's position is nothing but post-operatively, how does the patient usually, suppose the patient underwent a major surgery under general anesthesia. What do? You'll elevate the head, na? 30 degrees or 45 degrees you'll elevate. That's called Fowler's position. Why are you doing it? Because if you keep the patient, normally GA, whenever you give a GA, there is slight accumulation of fluids into your lung spaces. Okay. So you want it to relieve. And if you're telling the patient to sleep flat, the area of the lungs where the air goes in, you're reducing it. But when you sit, you're increasing that area. The lung can expand more freely whenever the patient is in slightly elevated position. And all that liquid which is there, it will come and accumulate down. Slowly it will relieve, but it will come and accumulate down. But if you're sleeping, kinda mottam, down part, completely it will accumulate. It will reduce the breathing space of the lung, and the patient can, the saturations of the lung of the patient will fall down. You don't want that. The patient has to breathe normally na, after a GA. That's why you'll maintain a Fowler's position. This is also done to even minimize pain. So after surgery, place the client in a semi-Fowler's position. This will help to reduce tension in the suture and abdominal organs. Okay, it is also done for post-surgical things, And also, if you remember, mm, one few of the doctors, they'll come and do tapping, or they'll come and hit the back of the patient. That is also to reduce the edema, pulmonary edema, if the patient has post operatively. Next, inflammatory bowel disease. I already explained the two things: Crohn's and ulcerative colitis. Okay, ulcerative colitis is sincere fellow but can cause cancer. Crohn's is a naughty fellow which has skip lesions, but it will rarely end up into cancer unless it occurs in colonic region. Okay, it can occur anywhere. Next, it is an autoimmune disease which include Crohn's and ulcerative colitis. Ulcerative colitis, I've already told you, it's a disease of colon and rectum. Hmm? Crohn's disease involves all layers of the bowel wall and can occur anywhere in GI tract from mouth to anus. Hence, you have the skip lesions. You have a problem, again a normal tissue, again a problem, again a normal tissue, that is Crohn's. Continuous in the rectal area, in the colonic area, if you have a continuous issue, it's ulcerative colitis. So you need to know different kind of position. This is prone. This is how many of you, whenever, imagine if you're sleeping on a bed, do it on yourself. How do you remember? This is supine. Supine is where your back touches the bed. Okay. Prone is when you are sleeping on your tummy. Hmm? Next, this is dorsal recumbent. Dorsal means the patient is sleeping on the dorsal. This piche ka area is called dorsum. This area is called ventral. Ventral. So patient is sleeping on the dorsal recumbent. You're trying to put flex the knee a bit, and you're trying to separate the knee. This is all. It's also done for certain procedures or to examine that area. Suppose if you're checking a female and you're doing a vaginal examination, you put them in this dorsal recumbent position. Lithotomy. Many of you know what lithotomy is. This is used for normal deliveries. Also, it can be used whenever you're doing a hysteroscopy. You're trying to pass a scope into the uterus. Okay. This is standing. Okay. And यहाँ पे the anal area and all these are all checked with anoscope, proctoscope. You can do that. This is Sims position. Sims position is, even this can be used for checking the anal area. If the patient is slightly sleeping on the lateral side and one of the limb is flexed, other limb is extended. Simple. Just remember it as Sims posterior view. This is knee chest. Okay. What are you doing here? The knee is near the bed. The chest is also lying on the bed. Hence, it is called knee chest. This is squatting. Squatting is, what do you call this? Malasan, you'd say. Malasan in yoga. This is very important, squatting. Actually, squatting is like they'll put both their legs down in Malasan. You're supposed to sit like this. Is very good for your bowels. You'll have free motion. So people who are suffering with constipation, do, please don't think that the solution for everything is medicines and surgery. It's not like that. Have a good healthy lifestyle, eat proper food, be aware of what you're eating, and also do some kind of exercises and include yoga in your life. We should give importance to Indian science. Yoga is like so many years old, and if you do all this, you'll not end up into major complications very soon in your life. This is squatting. Squatting is the patient is squatting, sitting down, trying to sit down whenever they use a Indian lavatory. This is sitting, of course. Who doesn't know sitting? That's what we do all the day. This is semi-fowlers. यहाँ पे what are you doing? You're elevating the patient's head to 45 to 60 degrees. This is done in most of the wards. That's what you do, because this helps in easy breathing, reduces the pain. If you are like, suppose the patient underwent an abdominal surgery and you're making the patient sleep supine. Firstly, after GA, supine position is not recommended because of the edema post-surgical or post-GA. There will be some kind of pulmonary edema. The patient will have difficulty breathing. If you also sleep, what happens? The skin over the abdomen stretches. Na? If there is stretch and you have sutures, you'll have stretch pain. You don't want that. You want the skin to be soft and supple there. So what you do, once you elevate the patient, that stretch is gone. So the pain is also reduced. Pillow. So what are you doing here? You're supporting the head with a pillow. You're also supporting the neck here and upper back. This is to prevent the hyperextension of the neck. Then pillow under the forearms to eliminate pull on the shoulder. You don't want any kind of pull on the shoulder, and assist venal blood flow from hands and lower arms. So from hands and lower arms, all that venous return should be normal. If you're resting it on a very hard surface, you'll have some kind of stasis and edema. We don't want that. So keeping a soft pillow here below the forearm. Next, small pillow under the thighs. This is to flex the knees and to prevent hyperextension of the knees. So you're slightly flexing the knees here. You can see, na? Below this thigh, you're putting a pillow. What it will do, it will slightly elevate your thigh and it will cause flexion at your knee instead of hyperextension at your knee. You want it slightly flexed like this. You don't want it hyperextended. Hmm? Then you have trochanter roll, lateral to femur. Femur is nothing but a thigh bone. You have a trochanter roll here. This is to prevent external rotation of the hip. You don't want the hip to externally rotate. You want to keep it straight as possible. Next, you have footboard. Here you have a footboard. This is to provide support for dorsiflexion and to prevent plantar flexion. So if patient has a foot drop, imagine sciatic nerve or common peroneal nerve. These two nerves damage can cause foot drop. What are the two nerves? Common peroneal and then you have sciatic. Many of you know what sciatic nerve is, na? That nerve goes from the bump area. Nice thick nerve. In the thick nerve. So this nerve and this nerve can cause foot drop. So foot drop ante endi? Imagine this is your imagine. How can I show you? Anyways, imagine this is your foot. Okay, if you're trying to push it above, it's called dorsiflexion. If you're trying to push it down, it's called plantar flexion. Okay, foot drop means what? The foot loses to dorsiflex. It cannot dorsiflex. The foot will end up into dropping like this. Simple. So why are we keeping a footboard here is to keep that foot into dorsiflexion and to prevent plantar flexion or that foot drop. Simple. ఇక్కడ నేను కాలు చూపిస్తున్నాను చూడు కింద కాలు చూపిస్తున్నా దిస్ ఇస్ డార్సిఫ్లెక్షన్ దిస్ ఇస్ ప్లాంటార్ ఫ్లెక్షన్ ఓకే so Fowler's and semi-Fowler's. In Fowler's position, patient on the bed is at 30 degrees angle. Remember that. 30 degrees angle is Fowler's position. Semi-Fowler is 45 degrees. It is useful with patient which has breathing problem to improve lung expansion because diaphragm is down kada. Whenever you are like sitting or you are on the Fowler position, whenever in that position, diaphragm is pushed down because of gravity. But if you are supine, the diaphragm goes a little up because there is also pressure in the abdomen. It will push the diaphragm. So you want the patient to breathe easy, put him in Fowler's position. If they ask you why are you keeping the patient in Fowler's position, first of all, Fowler's means 30 degrees, semi-Fowler's means 45 to 60 degrees. Why are you doing it? Firstly, post-operatively to maintain breathing. Okay, or if that patient has any kind of a breathing difficulty, you have to keep them into Fowler's. Secondly is to prevent pain. These two things you remember, it's enough. Fowler, remember the name. Okay, esophagus. Esophagus, it's a collapsible tube. This area, you have your esophagus. It's your food pipe. It's a collapsible tube. Okay, it is 25 centimeters in length, located in the mediastinum. Mediastinum is nothing but the cavity, the space between your heart and the spine. That area is all called mediastinum. It is located in the thoracic cavity. It is located anterior to spine, so it is in front of the spine, and it is posterior. It is behind the trachea. Trachea is nothing but your windpipe. This what you can feel here is trachea. Just behind it is the esophagus. So it is behind trachea and heart, and it is in front of the spine. It passes through the diaphragm at an opening called diaphragmatic hiatus. So diaphragm. So if you take, this is your thoracic cavity and this is your abdominal cavity. I'm just drawing something very silly. Don't think your body looks like this. This is just to differentiate the cavities. This is thoracic, this is abdominal. So your esophagus passes like this. Yahan pe you have your diaphragm. Na? In this diaphragm, you'll have small openings through which this aorta, okay, your esophagus, all this has to pass into the abdomen. So esophagus passes into the diaphragm, through diaphragm into the abdomen at that area called diaphragmatic hiatus. Then you have two sphincters, upper esophageal sphincter, lower esophageal sphincter. Where is upper esophageal sphincter? It is at this area, cricopharyngeal junction. You have it at upper end of that esophagus has got a sphincter. What is it helpful for? Whenever you have peristalsis, you have to prevent regurgitation of the food which is in the esophagus and stomach to come and regurgitate into the mouth. If it is regurgitating into your mouth, whatever is into your stomach and esophagus, it means something is wrong with your upper esophageal sphincter here. Second, lower esophageal sphincter. Lower esophageal sphincter, what does it do? It prevents the stomach contents into entering back into the esophagus. So esophagus contents are entering into stomach, right? So if the sphincter is loose, whatever the stomach is digesting, now all these things when the stomach is trying to contract, this can have a backward flow into the esophagus. Imagine if it goes along with that acid, you'll feel that burn, na? You'll call it, na? You know what is GERD, right? Gastroesophageal reflux. So you have that burning sensation. That's because your lower esophageal sphincter is gone. If that sphincter is, if there's some problem with the lower esophageal sphincter, that's when you develop GERD. Most of the patients have it, GERD. If the lower esophageal sphincter fails to close properly, it leads to GERD, and this prolonged GERD, prolonged exposure to that acid can change the epithelium. Normally, it is squamous epithelium, no, ciliated epithelium. Okay, that will become columnar because of this continuous cuboidal columnar epithelium lo మారిపోతుంది because continuously you're trying to put throw acid on it. So what happens to prevent worsening, this area undergoes complete transformation from one epithelium to other epithelium. It's called Barrett's esophagus here. यहाँ पे. One second, just let me check properly so that I don't give you wrong information. No, 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 man. We're almost there. Another 5 slides, we're done with this. One second. Yeah. So normally you have squamous. Squamous means what? Flat epithelium. This is the flat epithelium. This is the squamous epithelium. This is normal, what an esophagus is supposed to have. But what happens because of the repeated exposure to that acid, this undergoes a change, okay? And that becomes columnar, tall cells it will become. And that area will look velvety. Whenever we do an endoscopy, it will look more thick, it will look more velvety. That is called Barrett's esophagus. And this Barrett's esophagus, if we leave it, and we don't treat this GERD problem, it can end up into cancer. It can end up into adenocarcinoma of that esophagus and the external sphincter of the anus. So upper portion of the esophagus, wherever you are like just swallowing your food, that and the anus, both are under our control, voluntary control. You can control it. But the remaining part of the gut is involuntary. You can't control it. Okay. Suppose you want to go and poop. You have to go to the washroom. Urgent go vastundi. Can you control? You can control na, for some time. That's because you have control on the anus. But the remaining part in between you can't control. You can control here. You want to swallow, but you don't like the food. You'll control, na? You'll not end up swallowing. You'll end up spitting it out. This area, upper part of the esophagus, is also under your control. Both ends of the tube are under your control, but the whole tube in between is not under your control. So this is how the Barrett's esophagus is velvety appearance, because this normal pinkish epithelium is changed into this columnar epithelium at the lower junction. This is how it will look on an endoscopy. This is Barrett's esophagus. So you can see, no, this is all normal. Lower esophagus is supposed to look pinkish and normal. यहाँ पे क्या हो रहा है? It's all getting converted into columnar epithelium, reddish epithelium. This is Barrett's esophagus. What is sialadenitis? Sialadenitis is nothing but inflammation of salivary gland. Simple. Adenitis is gland, adeno is gland, itis is inflammation, sialadenitis is salivary gland inflammation. What do you do? When does this happen? Whenever you have a very bad oral hygiene, you don't brush. Okay. Then you discontinue medications which diminish salivation. You're reducing the amount of salivation in your mouth, anticholinergics if you're taking, that can lead into sialadenitis. Because for the free flowing, imagine that. Okay, let's not use that example. Just imagine that for proper hygiene of the mouth, all that excretions secretions have to be, the duct of the salivary gland has to be patent ante open undala. So all that exchanges keep all that salivary gland is supposed to produce a saliva. It is going into your mouth, it is digesting a little bit of food into your mouth, okay, and that's how it goes along with all the salivary liquids into your esophagus. But what happens if this is inflamed? That saliva, or suppose if you're taking drugs which reduce salivation, that can lead into this inflammation because you're blocking the duct. You're not allowing the saliva to come out of the duct. So that can lead into adenitis, irritation of the, you're you're trying to tamper the normal functioning of the salivary gland. What do you give here? One of the most commonest reasons is infections. I told you, na, staph has no panipata. It will go and cause issues. Staph and streptococcus are one of the main bacteria which cause most of the problems in our body. Okay, so you try to give antibiotics because it can be a bacterial infection. Secondly, it's very painful. What happens if there is if there is itis, inflammation? That salivary gland will swell, na? It will lead to severe pain. You can see it nicely. If your parotids are inflamed, you can see it here. Submandibular can be seen here. Submental can be seen here. They'll nicely swell, and that is very painful. So what you'll do, you'll give analgesics to reduce the pain. You can also give them anti-inflammatory drugs. Surgical drainage and excision of the gland and its duct. Even after all this pain doesn't reduce, the swelling doesn't reduce. What do? You surgically remove it off along with the duct. What is sialolithiasis? Lithiasis means stone formation. So salivary cannula in the duct of that salivary gland, stones are getting formed. Simple. Salivary calculi. Calculi is nothing but stone. Most common affected are submandibular. This is your mandible, no? Just below your mandible here on both sides you have submandibular glands. That is one of the most affected glands for salivary stones, ductal stones. Calculi are formed mainly from calcium and phosphate. How are the stones formed? What are the stones made of? Until they're made of what? Calcium and phosphate. Lithotripsy is a procedure. Lithotripsy is removal of that stone. Okay. I am very sure people who have worked in renal wards have heard about this lithotripsy procedure. They try to break the bladder stone. Na? Please go to OTs and see what they do. You don't have to do anything. You can stand and see. Next, something is called xerostomia. Xerostomia ante endi? This dry mouth. That can also cause problems. What do? You'll avoid irritating foods. You'll avoid irritating fluids. You'll prevent this. What are the irritating fluids? All the soda, all that Coca-Cola, Pepsi which you have now, also irritating. They are chemicals. And irritating foods is spicy food. నైస్ దాని మీద మంచి పచ్చి కారం వేసుకొని you want to eat over, you'll end up having, if you do that every day, you'll end up having all these problems. Next, increase the fluid intake, because if you're taking very less of fluids, it can lead to dryness. Very simple. Next, what is there? Stomatitis. Stoma means this area, mouth mein there is inflammation of the salivary gland. What do? You do here is you will do a periodic mouth care. Stomatitis is actually inflammation of the salivary gland, particularly gland. So what you want the inflammation to go down. You can also give antibiotics. You can also give anti-inflammatory. If it is an infection, you'll give antibiotics. Otherwise, you'll just give an anti-inflammatory drug and analgesia to reduce the pain. Along with that, you'll ask the patient to use some kind of, you have to improve the oral hygiene of the patient. So good brushing, using a nice mouthwash can all reduce the problem. Here, if you can see, this is the submandibular gland. This is actually a mandible. Okay, this is the angle of your mandible. Just below it, you can see how much that gland has swollen. Okay, it's a submandibular gland which has undergone some kind of inflammation. Hence, it has nicely swollen and it is extending posteriorly below the mandible. You can nicely it has become like that. Even from this view, if you see this side is normal. यहाँ पे you can see na nicely one bump. Manu, can we like change? I pin, yeah.
Let me bridge down.
Somebody is asking, मैम क्या पढ़ा रही है? आपका सब्जेक्ट पढ़ा रहे हैं. Just let me see those comments. Thank you, Dahlia. Is it Dahlia? Dahlia? How do you pronounce it? I think Dahlia ante flower kada.
Yeah.
Most of the nurses have these names. Daisy, Dahlia. Hi, Gauri. Hi, Dahlia. Thank you, Dahlia. Hi, Gayatri. Hi, Kashinath. Hi, Raunak. रौनक तुम्हारा सब्जेक्ट पढ़ा रही हूँ. इवन एट दिस स्टेज इफ यू से क्या पढ़ा रही हूँ, वेरी बैड. ओके ओके, सो लेट्स स्टार्ट. What is post operative? So successfully we have finished 213 slides. Okay, guys, it's an achievement for me, but I don't know about you guys. I'm hoping that you've understood what I've taught till now. Email.
I did not share the screen.
Okay. ఎట్లా తెలుస్తుంది?
I was just looking at this.
Okay. So post-operative monitoring following a cervical disc surgery. Sir has actually divided the topics. He's not continued the topic completely so that you guys don't get bored. If I keep talking about one thing continuously, anybody will get bored. So we keep shifting so that your minds are like nice and energetic. Okay. So post-operative monitoring following a cervical disc. So you have done a cervical disc surgery. There's a disc prolapse. You have removed that disc. You've done a surgery. What do you do after the surgery? Firstly, anybody knows you have to assess respiratory status of the patient. Is he breathing normally? You have to encourage deep breathing and coughing exercises. I told you, no, you'll keep them in Fowler's position nicely. I did my internship from Spania, so I had one of the surgical PGs. So she was doing her first year surgery. She just joined. So that ma'am used to love doing this, coming and hitting patients. So we had a post-op ward completely. So we were posted that night. I was posted along with her. She was like, "Maro, acha, Maro." That's what you do, especially if the men are admitted. She used to encourage the wives of the men to come and hit that fellow. That's the mocha, they're getting a chance to hit their husbands. So nicely, if you keep tapping on their backs, now whatever that accumulated fluid, it will come and accumulate down. All that edema will come and accumulate. It will get dissolved from there. That's why you do this coughing exercises or tapping exercises, hitting on the back. You ask the patient to cough because it will open up all that alveoli. Okay. Next, you look for laryngeal nerve damage because in this area you're doing a surgery. Anything you touch the neck, you have to check if there is any damage to the laryngeal nerve. What happens if the laryngeal nerve is damaged? You'll have hoarseness of the voice. The voice becomes more rough in texture. Okay. Uh, you will sound. If imagine I underwent a thyroid surgery, I'll start sounding more Rani Mukherjee into 10. That's how I will start. You know how Rani Mukherjee's voice, nice hoarse voice she has. More worse than that. You can't even understand. It will become very rough. That happens whenever your laryngeal nerve, it is on the sides here, if it is damaged. Next, inability to cough is also an indication that you have damaged the laryngeal nerve. Gaya comes in, laryngeal nerve. Okay, next, post operative monitoring following lumbar disc surgery. Now we spoke for cervical disc, na? So what are the other area where the disc prolapse can occur more commonly is lumbar area. So if you have done a surgery, what you do? Simple, assess movement. You need to know whether the nerve is functioning properly or not. Whichever nerve was being compromised, area lo, you have a normal pain, you have a normal sensation. Okay, you have a normal color in that area. How is the temperature? And you'll assess if there is any paresthesia, that tingling sensation is gone or not. If it is still persisting, means that nerve is still getting compressed. It has to relieve. That tingling sensation should go off. Okay. Next, you'll assess bowel and bladder movements because cauda equina branches are coming. No? All those goes and supplies the bowel and bladder. So if you have any kind of lower spinal injury, what happens is that nerve is completely cut off. Imagine if there is any some kind of an injury in that area, of that disc is going and prolapsing in that area and causing a compression on these nerves, those nerves which supply the bowels and the bladder. What happens? The patient has no control on the urine. They will end up passing urine on the bed. They have no control over the motion. They'll end up passing motion on the bed. So this you have to assess whether they're able to control or not, whether the bladder movement and the bowel movement is normal or not. Client has to be in supine position. Supine position matlab you're sleeping on your back, not on your prone. ठीक है? Prone matlab sleeping on tummy. यहाँ पे you're sleeping on your back, so supine position following the surgery. Avoid prolonged sitting as it causes pressure in the surgical site. Simple. If you have a lumbar region and you're sitting, you're causing more pressure on the lumbar region. You don't want that. You tell the patient to beta so jao. What are hemorrhoids? Everybody knows hemorrhoids because it's one of the most important complications you see irrespective of age. So when does it happen? If you have very constipated bowels. So whenever you have constipation, what do? You sit on the commode and you push it. You put more pressure. That can lead into hemorrhoids. Do you know that? You don't do it. Sometimes what happens is if you are like very old patient and you do all these things, it can end up into prolapse. That even that rectum can come out because of the increased pressure you're causing. So you don't do all that. Okay. Constipation hai, so you try to drink more water, take more fibers. Don't put increased pressure. Allow the body to pass the motion naturally. Okay. Hemorrhoids are swollen veins, not arteries. The swollen veins in the anal canal caused by chronic excessive pressure from straining during a bowel movement. Persistent diarrhea. So, why diarrhea? Because if there is constant diarrhea, that area of your anus isn't it irritated? Irritate aitadi kada, kachapan. Always it's wet. Diarrhea aitune undi. Irritate aitadi. Irritate annappudu emaitadi? Hemorrhoids can occur. Okay. Or pregnancy. Even in pregnancy, hemorrhoids are also very common because even constipation is very common finding in pregnancy because of that hormones. Types, there are two types of hemorrhoids: internal, external. Remember that external hemorrhoids are painful, internal hemorrhoids are not painful, mostly not painful. External ones are actually more painful. So internal hemorrhoids are usually painless. There may be bright red rectal bleeding during or following a bowel movement. So the patient is passing motion. It can be covered with a layer of blood, okay, a thin layer of blood along with that mucus. That is called hematochezia. Hmm? That happens whenever you have internal hemorrhoids because our area from that area the feces is passing, na? So it will irritate at the area. Whenever it irritates, it chips off the layer, whichever that healed ulcer is there, na, it chips off. Again, bleeding occurs from that area. This is what will happen in internal hemorrhoids. You can have hematochezia, and you can see it on toilet paper or drips into the toilet bowl. You can see it is covered. You have bleeding while passing motion. It's called hematochezia. What is the treatment? Avoid constipation. If you have excessive diarrhea, you will give anti-diarrheal drugs. If you have constipation, you will increase the bowel movements by giving laxatives, okay, or using elastic bands. You have to, if that internal hemorrhoids, you keep pushing it, even those can prolapse, they can come out and become like external hemorrhoids. You don't want that. So what you do is you try to pull them inside with elastic bands. It's a tiny surgical procedure into the rectum. Surgery is needed only for small number of patients with very large, painful, persistent hemorrhoids, especially if the patient has external hemorrhoids. Na? What happens? They will become thrombosed. They're veins, na? What happens if they stasis? It will become into a thrombose. It will become a clot. And wherever there is a clot, then you'll have pain. So that area has to be relieved. You're supposed to do a thrombectomy. You're removing the thrombus. Okay, that is the surgical procedure which you're doing. You'll do it very rarely. Regular guy, you don't see people undergoing hemorrhoids, na? Day in, day out. No, it's not like that. You do it only if they're in extreme pain and that pain is not relieving even after all the things you have done. Okay? Removing the clot in the vein under local anesthesia is also known as hemorrhoidectomy. Ectomy is removal. Hemorrhoid is being removed, hence hemorrhoidectomy. Assist the client to assume a prone or a side lying position. What did we do for disc prolapse? We asked the patient to sleep supine after surgery. But यहाँ पे what you're telling the patient, you have to sleep prone because you don't want to cause pressure in the anal area. Anal area is down, na? So you want to keep it as up as possible. You don't want any kind of edema or stasis to occur in that area. How do you do it? If you keep it above, there is no stasis because of gravity. Ardhamenda, you understood? So you'll ask the patient to sleep prone on the tummy. It is to minimize the bleeding post surgical, obviously. It is the gastric. Okay, what is gastric outlet obstruction? So, what does the stomach, what is the last part of the stomach? It's the pylorus. So, if that pylorus undergoes hypertrophy or hyperplasia is increasing in number of cells, hypertrophy is increasing size of the cells. Okay, if the muscle layer in that pyloric region becomes more thick, what happens? All that lumen inside the pylorus becomes thin. There is an obstruction that is called gastric outlet obstruction. Simple. Because it's because of pylorus. What is the treatment here is you will try to do a surgery. There's a surgery's name, I'll tell you later. You will cut all that muscles to relieve the hypertrophy. And once you cut the muscles, all the tight muscles now will become released. So whenever the muscles are tight like this, hypertrophied, once you're releasing it, it will become loose. The lumen becomes more free and the obstruction is lost. What is fiber optic colonoscopy? Scopy is viewing, you're viewing the colon with a fiber optic device. There's no rocket science in this. Fiber optic colonoscopy. Direct visualization of the colon and cecum. You know what is cecum and colon. This can be diagnostic or therapeutic. Either you're trying to do a diagnostic procedure to know what is wrong inside, or you're doing a therapeutic. You know what is wrong with the patient, you're trying to treat the area. Okay. Next, patient is positioned initially on the left side. You'll make the patient to sleep mostly on the left side with legs drawn towards the chest. Both the legs are towards the chest, sleeping on the lateral side. Whenever we have period pains, how do you sleep? You try to put the knees above your chest, na? You try to sleep like a baby. Okay. Patient's position is kept on changing. So one side you have entered. Once you have entered inside, you'll ask the patient to keep on moving to see all the parts. Wahan pe. So during the procedure, you keep changing the posture of the patient. But whenever you start with the procedure, you make them to sleep on the left side with the knees touching the chest. Okay. Enema is given before. Obviously, if you don't give enema and you're trying to put a scope inside the anus and it is filled with all feces, how will you do the procedure? You can't. You have to keep all that area clean. There should not be any kind of feces. You're giving enema before the procedure. One day before the surgery, you will tell the patient to be on liquid diet. And from midnight, nail by mouth. Simple. Fluids, especially 2 to 3 days before. You'll tell the patient ki you keep taking fluids, don't take any solids because once you take solids, na feces can occur. It's difficult. Yeah. Patient is advised to maintain a clear liquid diet at noon, the day before surgery. Okay. Then NPO. NPO is nil by mouth, nil per mouth after midnight. From 12 o'clock in the night, you will ask the patient not to eat anything or drink anything from the mouth. What is palate? Palate is this area of above. Okay. The first part of that palate is called hard palate, which you can touch here immediately, and behind it is soft palate. Anterior part of the palate is formed by maxilla and palatine bone. Because it is formed by bone, just remember it's hard. Nice, you can feel it. Touch your upper palate and see, you can feel it. It's all hard. It is formed by the maxilla and the palatine bone. and पीछे का part of the palate is soft palate. It is formed by posterior part of the palate. What is odynophagia? Odynophagia is pain while swallowing, especially it occurs in this area, in the chest area. So whenever, imagine, have you ever felt any kind of pain, suddenly forcefully you drink water, sometimes it will go very painfully down, no? That's called odynophagia, which some of us experience. Okay, next, why does odynophagia occur is if you have any kind of obstruction in the lumen of the esophagus, that food particle is not able to go, or if you have painful peristalsis, that can lead into pain, especially when you're trying to swallow. Normally in our oral cavity, also in our vaginal cavity, also in our gut, normal bacteria or normal flora is lactobacillus acidophilus. The cardiac sphincter, lower, I just told you that you have two sphincters in your esophagus, no? Upper and lower. The upper sphincter is also called as cricopharyngeal sphincter. It's in the name. It's at the pharyngeal region, cricopharyngeal. Okay. The lower esophageal sphincter is lying just behind your heart. Just remember like that. Hence, it is called cardiac sphincter. It's nearer to your heart. It's called cardiac sphincter. The cardiac sphincter or the lower esophageal sphincter is located at the junction of esophagus and stomach. Lower, na? So it's in between the esophagus and stomach. It is to prevent the regurgitation of food and acid back into the esophagus. Upper esophageal sphincter is to prevent the food particles getting refluxed into your mouth. Understood? Very easy. Then again, coming back to 30 high yield points for your exam. Vitamin D deficiency, if it occurs in children, okay, it's called rickets. If it occurs in adults, it is called osteomalacia. Hmm? I told you, no, osteomalacia will have this soft bones. What are the cardinal symptoms of rickets? This is very important. These names you can't change it. It's a very common question, so you can't do any kind of changes here. Try to remember. What is craniotabes? I had another presentation, but I actually tried to put some pictures for you in my laptop, but my laptop is not listening to me today, so it's not opening. I don't know. It's 1945 year. That's very old laptop, so it's not functioning properly. So very sorry, I couldn't add pictures, but please go home, and this video is anyways there now in the YouTube, so you remember what slide it is, and go and check how these look on the Google images. Itla kanpistadi. You need to see how it looks like. Okay, then it's easier for you to understand. Craniotabes, it's there in the name. Cranium means something to do with your skull bones. Here you have thinning of the skull bones in rickets. Rachitic rosary. Rachitic rosary means, do we have? Okay, there's some space here. I'll explain. A picture unte. Rachitic rosary is actually X-ray finding of the rickets patient. So what happens is, okay, choose here. Can you see this red color? Huh? కనిపిస్తుందా రెడ్ కాదు సి ఓకేనా yellow చూస్ చేయాలా red is okay. So what happens is, imagine this is your sternum, tie like bone, you know na, it is sternum. यहाँ पे this is all your cartilage. All this yellow part is your cartilage. Okay. And all this is your bony ribs. You can see now clearly now. Just drawing some rough diagram. Sorry if it doesn't make sense. Blue juices thing అనిపిస్తుందా? Yeah. So these areas are called costochondral junctions. Costo is rib, chondrum is cartilage. Okay. This area between the cartilage and the rib is all inflamed, and they look like beads, as if you're wearing beads like this. Hence, it is called rosary beads laga. I think most of you Christians know what rosary beads are. So that's how it looks. Okay, that's it. Hence, it is called rachitic rosary. Okay, fancy name daniki. But you'll never forget because they're very typical. They're pathognomonic. You only see it in rickets. Okay. Then there is something called pigeon breast. Pigeon breast means, have you ever, all of you know how pigeons look. And if you say, I don't know, come on, you're not even a human. You know how a pigeon looks like. So the xiphisternum, the last part of your sternum is protruding outside. It's called pectus carinatum. Okay. So it is protruding outside. So normally, yeah. So imagine if this is the patient's Devada. It's so difficult to use. Should at least compliment sir for this. How he uses his God alone. So imagine there is a human. This is how the chest looks like normally. Okay. What happened? This is the chest. This is the back portion. Okay. What happens here, yahan pe is, this is how the chest will look. These are not breast. This is the sternal bone, which is actually coming and protruding outside like that. This part, the sternum will come and protrude outside. Last part of the sternum, Ziphy sternum will come and protrude outside. And they will have a very prominent chest, like this, literally. That is called pectus carinatum. Okay. It's also part of the rickets, pigeon breast, that's called. Then I already showed you what is bowing of the legs. Valgum is knock knees. You can also see valgum in rickets. That is also one of the findings. Bowing of the legs is also seen, which is varum, genu varum. Rum bottle on the maddelo. Okay. Waddling gait, of course. If both the knees are apart, they will have a waddling gait. Short stature. All those overall in rickets, they are not very tall. They're all short. Okay, rachitic rosary can be frequently seen in rickets. It's a classical beading of the osteochondral junctions of the rib. I just showed you, na color. Carpopedal spasm. What is carpopedal spasm? Is 1 second. Easy gatla cheppala. So, in your hands and your feet, sometimes in these ricket patients, you can have some kind of a painful contractions. That is called carpopedal spasms. It's also it occurs especially whenever the calcium levels are low in your body. Tetany, na? Whenever there is very less calcium in the body, what happens? Tetany can occur, spasms can occur, and they don't relieve. Even on giving a muscle relaxant doesn't relieve. Especially it happens in patients who have very less calcium. That is called carpopedal spasms, and this indicates hypocalcemia. Obviously, significant elevation of ESR and C-reactive proteins is seen during the actual phase of rheumatoid arthritis. Okay, rheumatoid arthritis is an autoimmune problem. So whenever you have inflammation in the body, ESR and CRP both are raised. It is raised in most of the inflammatory conditions, but it is very significantly raised in rheumatoid arthritis. Arthritis enduku because arthritis, itis, it is undergoing an inflammation. Hmm? Carpal tunnel syndrome, I already told you, it's a compression of the median nerve. Small intestine, is the longest segment of your GI system. Everybody knows. All that gajibiji snake-like thing is your small intestine. Even looking at that snakes, you can know you can even blindly you can say, okay, this will be the longest part of your GI system. It is divided into three main parts. Firstly, it is duodenum. Second, it is jejunum, and third is ileum. So what happens is, यहाँ पे the shortest part in that whole small intestine is your duodenum, because it's only 25 centimeters, even less than your big scale. Your big scale is 30 centimeters, na? Remove another 5 centimeters. 25 centimeters is your duodenum. That's the shortest part of your small intestine. And then you have an 8 feet jejunum. This room can be almost like 15 feet until 15, 16 feet. Imagine 12 feet of your ileum, 8 feet of your jejunum. Okay, 8 feet is jejunum, ileum is 12 feet. So longest part in your small intestine is the ileum. And absorption, I just told you in malabsorption, what are we doing in that uh, bariatric surgery? In one of the surgeries, we are bypassing that area. Na? So I told you, ileum is the place where B12 is getting absorbed. And if you're bypassing it, what happens? B12 will not get absorbed. That patient will have B12 deficiency. So ileum is the area where absorption of B12 takes place. And for this absorption of B12, there is something called intrinsic factor. Okay. And this intrinsic factor is being produced in your stomach. Got it? Intrinsic factor. Stomach is there. Stomach mein you have pepsinogen. Okay. You have IF, intrinsic factor. You have HCl, which is nothing but hydrochloric acid, which is your acid. IF and HCl are produced by parietal cells in the stomach. You also have something called mucus producing cells. Chala rakarakala cells unnai. We will not go into details, but remember that parietal cells are what which produce. It's also part of your slides. So that's why I'm explaining it to you. Parietal cells produce intrinsic factor and acid, HCl. This intrinsic factor is mixed up with the food. That's how, along with it, it goes into the ileum. Once that goes into the ileum, this intrinsic factor is required for the absorption of vitamin B12 into your ileum. Okay, just remember that much. What happens in pernicious anemia? There is an anemia with name pernicious. Pernicious anemia. So these people will have deficiency of this IF. Intrinsic factor is absent in these people. What happens once the intrinsic factor is absent? Even if you take how much ever B12 you want, it will not get absorbed. Simple. That will lead into megaloblastic anemia. B12 deficiency causes RBCs to become more fat. Okay, iron deficiency causes RBC to become more lean, microcytic, chota chota ho jata hai. Okay, B12 is causing macrocytic anemia. That pernicious anemia occurs because of this IF deficiency, which IF is required for B12 absorption. So if this IF is not being produced into the body, even how much ever you give oral B12, it will not get absorbed. So in such patients, what do? You'll give IV B12. You'll give that B12 injection in the saline bottle and Ekistal. That's how you give them. Because IV, what happens directly, it is going into your system. It's not going into your GI system. But oral, what happens? Oral, it has to get absorbed. So oral tablets in pernicious anemia doesn't work, B12 deficiency. Next, the common bile duct allows the passage of both bile and pancreatic secretion. So what happens is, from the bile sac, a duct comes. Okay, gallbladder untadi kada. You have gallbladder, right, just below your liver. That is what from that is the area where the bile is produced. So it has a duct which comes, and pancreas also has a duct which comes. Both of them come and get combined and form a common bile duct. Okay, and that opens into the duodenum. That area is called ampulla of Vater. Okay, ampulla of Vater. It is there here. Ampulla of Vater. And this ampulla of Vater has a valve. It has a door. That door is called sphincter of Oddi. Hmm? It is surrounded completely by that sphincter. That is what it is controlling the duct from opening or closing. Simple. Ampulla of Vater, you remember, that is the place, or that area is called ampulla of Vater because वहाँ पे क्या होता है? Common bile duct. That's a combination of bile duct and your pancreatic duct, both opening into second part of duodenum. That area is called ampulla of Vater, and surrounding a sphincter, which is also called a sphincter of Oddi. These names you can't forget because you'll not find this again in any part of your body. So you have to do batti. We people, we read it daily, so we remember as doctors, but for you people it's little difficult. But it's anatomy, you can't do anything about it. Sphincter of OD contains three sphincters. That much you remember. Bas hai. Okay. Junction between small intestine and large intestine is a cecum. So the small intestine, all the gajibiji snakes, all that snakes will come and open into the large intestine. This area is called cecum. This area. Okay. यहाँ पे it is called ileocecal junction. Okay, the cecum is opening into your large intestine. यहाँ पे also you have a ileocecal valve that controls. Why is that valve present? That valve allows the movement from only one direction. Why do you have valves in your veins? Why do you have valves in your veins? Because first of all, veins are all lazy. Okay, they're not very thick, they're not very active like arteries. They do work slowly. And if the veins are very lax, what happens? The back force can occur. There can be stasis of the blood. You don't want it. You want the blood to go into one direction only. So there has to be some kind of support. Okay, that support is called valves. Hence you have valves in the veins to prevent this backward flow of the blood. Hmm? Why? Especially why? Because veins are going against gravity, na? So they need more support. They need some kind of push to go up. Hmm? Artery is going with the gravity. Veins are not like that. Veins are going against the gravity. They have to come from down to up towards your heart. So you need some kind of push. Whenever things are going against gravity, they can come and fall back. You don't want that. If that happens, varicosities occurs. यहाँ पे also very same. You have ileocecal valve. It allows the food particles to enter from your small intestine into large intestine. Also it prevents the gut bacteria. Where are your gut bacteria? In the small intestine you'll not have bacteria. You'll have it in your colon. That colonic bacteria, if it enters into the ileum, it will cause problems. Even that it will prevent that valve. Okay. So what does the valve do is it'll tell the food, go into the colon, don't come back. Hey bacteria, you are not allowed inside. That is what the function of the ileocecal valve is. So I'll read the part here. Yeah. So junction between small intestine and the large intestine is a cecum, which is located in your right lower quadrant. Everybody knows your cecum and your large intestine starts from your right quadrant. It is opening into your ascending colon. That is into your right quadrant. Just at that area you have your appendix. Hmm? Ileocecal valve is located here. I just told you. Ileocecal valve controls the entry of content into the large intestine as well as it prevents the reflux of bacteria from large to small intestine. Vermiform, worm-like appendix is present. Vermiform is worm-like. Appendix is located near the ileocecal junction in the right lower quadrant. And deficiency of B12 results in pernicious anemia. I just told you all that in the previous slide. Simple. What is capsule endoscopy? Capsules. I'm very sure you all have swallowed at least one or two capsules in your life. You know how a capsule looks. Imagine if you're putting a camera inside that capsule. That's how it looks. It's a capsule which has a camera. You'll ask the patient to swallow it, and you have some kind of you have the patient will be wearing a belt, abdominal belt, to which sensors are attached. So when this capsule enters into your body, it will take all pictures and it will send all these signals to the sensors on your body, and that is what which captures the pictures. Okay, and that capsule is being excreted out into your feces. This is in the name. We're doing an endoscopy by telling the patient to swallow a capsule. A small camera which looks like a capsule, which will be swallowed. It will take a series of pictures of the GI cavity and it will send to the externally worn source. Externally worn source is what you wear in your tummy. That belt is worn. So to that belt, you have sensors attached. After 8 to 72 hours, 8 to 72, the 3 days, this capsule will be eliminated from the body naturally. You'll pass it in your feces. What you have to do before doing this endoscopy, before any endoscopy, you'll tell the patient to be nil by mouth from midnight. Then you'll do bowel preparation. You want the bowels to be cleaned up. You'll give laxatives before the procedure. Next. Here, body means stomach has different parts. It has cardia, it has pylorus, it has lesser curvature, it has greater curvature, it has body. That beach ka part, na, the middle part of the stomach, suppose I draw it. Okay, this is the greater curvature. This is the lesser curvature. This is the cardia. This is this area. This all area is body. This is the pylorus. Okay, these are the parts of the stomach. The body of the stomach is central and it is also the largest part of the stomach. Simple. The semi-fluid mass of partially, once you're eating, you're mixing it with all juices, you're mixing it with water. All that is all like chewed in your mouth and it goes into your esophagus and goes into your stomach. So it is in semi-fluid mass. Okay? The consistency of that food is not completely solid, it is semi-fluid. Okay, all that partially digested food expelled. Okay, what happens is you're getting a semi solid food. Once you're chewing it, you're reducing the size of the food, it enters into your stomach. In the stomach, what happens? It is all mixed up with the acid, it is mixed up with the HCl and intrinsic factor. All that thing comes into the duodenum. That acid mixed semi fluid content of the stomach which is entering into the duodenum is called chyme. This is the one you're supposed to remember. Chyme. Whenever they ask you what is chyme, bolte you should tell it. What does chyme contain? It has HCl. It has all the semi-solid or semi-liquid food particle. There's intrinsic factor. Just remember this much. Mucus रहता है उसमें. Remember why is it called chyme? Because mainly it is getting mixed up with the acid. What is pyloric stenosis? Stenosis means what? Reducing of the lumen. Stenosis refers to narrowing of the pyloric sphincter. Simple. Parietal cells, I told you, parietal cells are ones which produce HCl and intrinsic factor. Intrinsic factor will become active in the ileum for absorption of B12. Okay. Intrinsic factor is essential for the absorption of B12. Chief cells, there are something called chief cells which produce pepsinogen. Pepsinogen is an inactive form of enzyme. It will become pepsin, which becomes active. What is pepsin required for? Remember P for pepsin, P for protein. It is required to make the protein which we eat to be to break it down into simpler molecules. Simple. It is for digestion of the protein, pepsinogen. Okay. What is the pH of the gastric juice? Because it's acidic, it is 1.5 to 3.5. HCl is 1.5 to 3.5 pH. Okay, for IBD, I already told you what are the things which we are supposed to keep in mind. We are not supposed to irritate the bowel more. Already IBD ante what? It's already inflamed. We are supposed to give the bowel some rest. Okay, so what are you doing? You're trying to maintain a good diet. What do? You're supposed to tell the patient to take high protein, high calorie diet, low residue. Low residue means which doesn't stay in your body, which is easily digested. Okay, with supplementary vitamin. Obviously, whenever you have IBD, if you imagine in IBD you have constant diarrhea, what happens? Malabsorption occurs. No? Whatever you eat, what will get absorbed? It will not get absorbed. They will have nutritional deficiency. So what you'll do, you'll also give them vitamins. Also, you'll give them iron because iron also is being absorbed into your GI system. Food items which cause diarrhea should be avoided. So spicy, smoked foods, barbecue nation kelli manchiga barbecue tinnarante IBD aitadi. So you have to be careful. All that smoked foods, coal use chesedi, all spicy food. Don't eat it very regularly, especially in people who have IBD are not supposed to have it that regularly. Okay. What is the pharmacological therapy? What do you give? Patient ki chala pain untadi. Patient is in extreme pain and irritated. You sedate the patient because the patient has to take rest. Okay. Anti-diarrhea, because there's diarrhea and Crohn's and ulcerative colitis, you're supposed to decrease the diarrhea. Antiperistalsis. Diarrhea ante the overactive peristalsis. Continuously the body is trying to push things outside. So reduce the peristalsis to give rest to the bowel. We'll tell Jojo to the bubble also. We'll tell Jojo to the patient also. Simple. Aminosalicylate and sulfasalazine. These are the anti-inflammatory drugs. The bowels are inflamed. No? You're supposed to reduce the redness of the bowels. So you'll give these drugs. In sometimes you can also give steroids. In inflammation, everybody knows you can give steroids. So corticosteroids preparations are used to manage inflammation. Surgical is done only when all this doesn't work. What is the surgical management here? You're doing a stricture plasty. You're blocking whichever area is completely inflamed, now what happens? The lumen becomes very narrowed. That is the source of pain for the patient. What you will do is you'll remove all that stricture, which what happens? You've seen what happens if acid comes and falls on your skin. It becomes very contraction aitadi kada. It all comes very close kada. Imagine if that is happening in your bowel. Stricture occurs. You're trying to relieve that stricture. You're trying to open up that bubble which has completely gone into stricture. So blocked narrow section of the bubble is widened, leaving intact. Constant inflammation can cause irritated bowels, and this irritated bowels can cause there can be adhesions in between them. That is the reason why this end up into strictures. You're trying to remove all these adhesions. You're trying to relieve that stricture. It's called stricture plasty. Other than this, what one more operation what you can do is this problem IBD is happening in the colon region, mostly in the colon and the ileum region. What you're doing, you're removing of that colon. Simple. Either you do a colonectomy, okay, you're removing of the colon, and that ileum, that cecum area, ileum cecum, whatever is remained, you're trying to outpouch it out. You're causing a stoma, you're causing a outpouching. You're trying to pass feces with the opening stoma on the abdominal wall. Simple. You know, na? You have that bag, fecal bag untadi baita. That is one thing you can do. Second thing, if you want to avoid this kind of opening on the skin, what you can do is you'll do a total colectomy. You're removing off the colon, and you're doing continent ileostomy. Yahan pe what you do is colon is completely removed, and the ileum, which is you make a reservoir out of it. Okay, in that, instead of completely opening the ileum outside into from your stomach abdominal wall to outside to the outpouching, yahan pe what you're doing is you're causing a reservoir. You're making it into a sac, and to the down part of the sac na, you're attaching a catheter. That catheter, you're completely removing off all the contents which is getting accumulated in the reservoir of the ileum. Just remember that reservoir of the ileum is being formed in this procedure. This is chala in depth. మీకు అవసరం ఉండదు. Even we as normal MBBS students also don't go way into depth of it. Usually this is done after your surgical if you're a GS, if you're a surgical PG, or you're thinking about a gastroenterology seat, then you think about all this. Just listen. Enta gurtuntado you remember. Things which you don't remember, don't worry about it. At least be very strong with your basics. Okay. So this is one thing. And then next thing you call it as total colectomy with ileoanal anastomosis. What are you doing? Anum you're not removing. The anal part is there, na? That you're not removing. That beach ka part, the colon you have completely removed. Ascending, transverse, descending colon you have removed. Okay. Anal is being retained. You're connecting that last part of the ileum to this anus. So the normal defecation is being restored. Yahan pe. Simple. You're connecting that end, this end. That's it. Okay. Total colectomy with ileoanal anastomosis. Colon is completely removed and ileum is connected to the anus. There is no external stoma because you're connecting it to the anus. Now, again, from the anal aperture only, the patient is going to defecate. Voluntary defecation is preserved through intact anus. Simple. That procedure, many of them like. Nobody wants to carry that kind of a bag, fecal bag outside. Also, whenever there is a fecal bag over on the skin, if they're diabetic, imagine how much of infection can occur in that area. They are prone to infections. Anatomy, because feces has a lot of bacteria. Anatomy and physiology of GI system. GI system extends. You know what is GI? It is from your mouth to the anus. Total length is 23 to 26 feet. That much amount of GI system, that much length, you're carrying it in the body. Okay, part of the GI system includes mouth, pharynx, esophagus, stomach, small intestine, large intestine, rectum, and anus. This everybody knows. You're learning it from your school. Average length of GI tract is 7 to 9 meters, that is almost 30 feet. Okay. Large intestine, total length of the large intestine is approximately 1.5 meters and is divided into three main parts. You have the cecum part, which is just that ileum entering into the colon. Then you have the colon. Colon may have three parts again: ascending, transverse, descending, sigmoid colon, S-shaped colon, and then finally ending up into rectum and then anus. This much you know. Colon is further divided as in ending colon. So colon is further divided as ending colon, the shortest portion of the colon, niche ka part. Okay. Then you have ascending. Okay, that is ascending. Sorry, guys. This is ascending colon. Ascending colon is the shortest portion of the colon. Whichever is ascending up is the shortest portion. And then you have a transverse colon. Then you have a descending colon. Sorry, this side. Descending colon for you guys, I'm saying. Sigmoid colon. And then that continues as rectum. And again, rectum continues as anus. Simple. Network of striated muscles form both internal and external anal sphincter. So even in anus, you have an internal sphincter, you have an external sphincter. Why, where, not required. Just remember it as two sphincters. One is which is internal, other thing is external. Remember that external sphincter is voluntary, it is under our control. We can control it. Until you're out, but you want to go and use washroom, but you're in Nampally exhibition. You know how dirty the washrooms, you can't go. There's no washroom in Nampally exhibition. What you will do, you'll control for 1 hour. That happens only if you have some kind of a voluntary control on your anal sphincter or your mouth. If you eat something, definitely something is going to go wrong. Okay. So because you have to control, that control is in your hand, you're able to control. Okay. Finally, you'll go home and you'll use the washroom. 30 high yield points for nursing exams. Cubital, anything which means cubital means your elbow. This is your cubital area. So yahan pe in this corner you have your ulnar nerve going. Okay. Any ghafla, anything happens, your ulnar nerve can get damaged here. That is cubital tunnel syndrome. Remember that carpal tunnel mein median nerve is getting damaged. Yahan pe cubital tunnel syndrome mein ulnar nerve is getting damaged because it gets compressed between two heads of a muscle. Okay, it gets irritated. Whenever ulnar gets irritated, it can cause issue in these two fingers. Jadoo, you know, everybody has seen Koi Mil Gaya movie. You know how an alien hands look like. So remember alien hands. Okay, this two part, half of this ring finger and the little finger and this area is supplied by ulnar. This all part is supplied by median. Behind is supplied by your radial nerve. Foot drop, I already told you, common peroneal nerve or sciatic nerve. If both are damaged, either of them are damaged, can lead into foot drop. They're not able to dorsiflex. It's completely plantar flex like this. Okay. Pain around the pin site. Pin site is what? Where you're putting pins into your bone. External fixation, I told you, na? In that area, what is the nurse, as a nurse, what you're supposed to see? Is there any redness? Is there any increased warmth in that area? Is there a swelling? Is there a pleural discharge from that pin site? If there is there, what you do, you go and alert the doctor. Saying the doctor, there's something wrong with the pin site, kindly come and check. There could be an infection. Simple. Next, and if you ignore this as a nurse and you don't end up informing the doctor, and the doctor comes in the night for the checkup or the rounds, that particular doctor, that infection can seep into your bones, leading to osteomyelitis. You don't want that. Next, nurse should stand on the affected. I already told you, when you're trying to make the patient walk, on which side do you stand? The side which is affected, not on the normal side. Because if this is affected, the patient will fall on that side. So you're supposed to stand on that side to prevent that fall. Ala gurtu pettukondi. Remember like that. Next, I already told you anoscopy, proctoscopy, sigmoidoscopy. You know how a proctoscope looks. Everybody has seen a proctoscope. If you haven't, please go home and check how a proctoscope looks. Okay. What is it used for? Anoscope, it's in the name. You're trying to visualize anum. Proctoscope, you're trying to visualize rectum and anum. Sigmoidoscope, you're trying to visualize anum, rectum, and sigmoid colon. Simple. So which is the longest scope here? Whichever is sigmoidoscope. ఎందుకంటే దూరం వరకు చూడాలి. So that is common sense. It is the longest. Anoscope is used to visualize anus and rectum. Proctoscope is for visualization of the rectum. Sigmoidoscope is used for visualization of sigmoid colon. Patient is positioned in knee chest position. I told you, they'll make the patient to sleep on the back of the table, inclined about 45 degrees, and then you'll make the knees flex towards the chest. Okay. During the procedure, whenever you're trying to push that thing, the patient will feel like pushing it out. So you might have some kind of a bubble movement, a peristaltic movement, because definitely you're putting something inside like that. What this will think about something is coming inside, don't want it, push it out. Okay, so don't worry. Next, enema you'll give, of course. If it is all filled with feces, you can't do a scoping. Simple. You'll give an enema before the procedure. After the procedure, you will see if the patient has any kind of bleeding or if there's any kind of perforation. Because if you're doing it way too much roughly, you can end up perforating. All that area is all soft inside. So if you do it very roughly, you can cause damage to the wall of the rectum or the anus. You don't want any kind of perforation. If there is a perforation, what happens? All that fecal matter will go and get mixed up in that abdominal cavity. It will lead to peritonitis. The patient will have fever, rectal drainage can be there, abdominal discharge, and pain. Peritonitis, I just told you, inflammation of the peritoneum. Peritoneum is what? It's a layer which is covering all your. You have visceral and parietal peritoneum. You know, na? Everybody knows. Visceral peritoneum is covering all your organs. Your parietal peritoneum is covering all your abdominal cavity. Okay. So if any kind of infection spreads into the abdominal cavity, it can irritate the peritoneum, leading into the peritonitis. And these people will go into septic shock. You have to be very careful. The serous membrane, okay, it's covering the abdominal cavity, peritoneum. Content of the abdominal organs, any organ, any kind of infection which is in the organs which leaks into the abdominal cavity as a result of trauma or perforation or an infection or an inflammation can cause irritation of the peritoneum leading to peritonitis. Immediate response of the intestinal tract in peritonitis is hypermotility followed by paralytic ileus. So what happens whenever there is peritonitis? First you'll have hypermotility, increased peristalsis. Immediately they go into spasm. Spasm ante endi, they go into paralytic ileus. There is no movement at all. First hyper chestadi, it will become more extremely activated and then it will become dead like a paralytic ileus. Manifestation ఏముంటది? Definitely there's itis, inflammation. You'll have severe pain. You'll have distended abdomen. Diffused pain in the abdomen which becomes constant and localized. Movements may aggravate the pain. Any kind of movement you do, it will aggravate the pain. There'll be severe pain. Rebound tenderness. You're trying to palpate the abdomen. You're pushing your hand inside. Once you remove it, now once that comes into normal position, that will cause severe pain. That's called rebound tenderness. And paralytic ileus, I told you. First it will have hypermotility and then it will become dead, like a paralysis. The whole ileum will become paralyzed. It's called paralytic ileus. There'll be no paralysis. How do you check bowel movements? You'll put your steth and you'll hear it with the stethoscope. Na? When you can't even hear 2 or 3 movements in that 1 minute, it means this can be a case of paralytic ileus. Then what else you can see? It's itis, inflammation. There can be infection. What happens? WBC's count will go high. Simple. Any infection, WBC increases. Elevated leukocyte count. Electrolyte abnormalities can occur. Electrolyte abnormalities is what which leads the patient into shock. Rigid, board-like abdomen. Because of that severe pain, okay, the abdomen is distended firstly and it's rigid. It will not, the patient will not allow to touch the abdomen. ముట్టుకోవడానికి ఇయ్యరు వాళ్ళు అంత పెయిన్ ఉంటుంది. Okay. Diagnosis, you'll do an X-ray. Whenever you do an X-ray, there will be air fluid levels, okay, in your distended bowel loops. ఆ bowel loops ఉంటాయి కదా, you'll have whitish area of liquid, then you have dark area, black area of air. అంతా ఇట్లా division ఉంటుంది. It's not like completely air. Normally your bowels are supposed to have air, but यहाँ पे क्या होता है? You'll have air fluid levels, okay. What is, because it's an inflammation, na? Serious, you'll have discharge. Then what do? You will do a peritoneal tap. You'll try to remove that peritoneal fluid and you'll do a culture and sensitivity to identify the cause. What is happening here? If you see feces, you should understand something. There's a perforation down. If you see some kind of acidic content, it means it can be a peptic ulcer disease. Food contents, all these things are because of peptic ulcer disease. Peptic ulcers, you know, no? It happens at the duodenum, and also in the stomach. If there is a ulcer and it perforates, all that contents can leak into the abdominal cavity. If there is any kind of bacteria, you can suspect that there is some other kind of an abscess in the body, in the abdominal cavity, which could be the primary source, which has perforated and it has caused leakage in the abdominal cavity, leading into peritonitis. Next, I already told you ileum is 12 feet. It's the longest part of the small intestine. Shortest part is your duodenum, which is 25 centimeters. Blood supply to small intestine is three things. Just remember the names. First, it is supplied by iliac trunk. Little part is supplied by celiac trunk. Sorry, celiac trunk. And then the second part is supplied by superior mesenteric artery. And then the last part is supplied by inferior mesenteric artery. You have triple blood supply to this small intestine. Hmm? Peyer's patches are nothing but they are lymphatic tissue, the lymphatic aggregates. Okay, and you see this in the ileum region, the small accumulation of lymphatic patches, which are called Peyer's patches, and you see them in the ileum. Tiny projections called villi and microvilli. You can, you know, now you have villi and microvilli. So if normally you don't have a flat gut surface like this, if you open, you can see like this projections. Why do you have it? This is to increase the absorption area of the villi. The villi and the microvilli, what they do is, if it is flat, imagine if the pipe is flat. If you put something into the pipe, ట్రీ అని పడిపోతుంది కదా కింద. ఇలా projections ఉంటే they'll stay for longer time. Increased absorption occurs. Okay, that is called villi and microvilli. They increase the area for absorption. Then you have transverse colon, ascending, transverse, descending colon. Transverse colon is 40 to 50 centimeters. It is the most mobile and the longest part of the large intestine. What is the shortest part? Ascending colon, I told you. Ascending colon is the shortest part. Transverse colon is the longest part. It's also very mobile. Okay. Blood supply, I already told you three things: celiac trunk, superior mesenteric, inferior mesenteric artery. Okay. But if you take colon is not being supplied by celiac trunk. Celiac trunk actually etla ante, okay, you got to బోర్ అవుతుందా? బాగానే ఉంది కదా. ఇట్స్ నాట్ బోరింగ్. Sir cracks very nice jokes. I'm very bad with it. మంచి జోక్స్ చెప్తారు. I draw here and show you ఎట్లా అనిపిస్తుంది. So where were we? Okay, so yeah, gut is divided into three parts: foregut, midgut, hindgut. This foregut is what which is being supplied by celiac trunk. Okay, a part of foregut is being supplied by celiac trunk. Once you think about midgut, actually foregut ends at duodenum, second part of duodenum. Okay, from second part of duodenum till the ileocecal junction or the small intestine part, you have the midgut. Hmm? And then colon and all will come under hindgut. Okay, so midgut mein you have again three supplies. You have triple supplies: celiac trunk, you have superior mesenteric artery, a part of the small intestine. Again, last part of this small intestine is supplied by inferior mesenteric artery. But remember, hindgut, which has colon in it, it is not supplied by celiac trunk. It is by SMA and IMA. Okay, this arterial supply of the gut is also very confusing for us. If I go into depth, there are a lot of branches, but we don't want to go in that depth. Just remember these three names, very important. So, superior mesenteric artery and inferior mesenteric artery provide blood supply to the colon. Then I spoke about Peyer's patches. Peyer's patches are lymphoid aggregates in the ileum. But myenteric, you have something called myenteric plexus. They're nothing but nervous plexus. It's also called as orbac plexus. Okay, orbac plexus. Okay, this is the myenteric. It's located between the longitudinal and the circular muscle layers of the GI tract. Actually, it's there everywhere. Full gut load between these two muscular regions, between the longitudinal and circular muscles, madhyalo, you have these nerves, uh, uh, aggregate of these nerves, which are also called as orbac plexus. It's also called as myenteric plexus. Then you have something called submucosal, which is just below the mucosa. Name itself says submucosal plexus. It's called Meissner's plexus. It is situated in the submucosal region between the circular muscles and mucosa. Just remember, it is just below the mucosa. It's called Meissner, which is between two layers of muscle. It's called myenteric. Okay, this butty. If I'm not going too much into description, just this, it is understood that's butty. Okay, next nervous. We'll do another. We'll finish this GI little bit, and I'll stop today. For today, did we started at 3:45? No, I'll end the class. Okay, another 5 minutes. Nerve supply of GI system, both sympathetic and parasympathetic nervous supply is there. Okay, sympathetic nervous supply exerts inhibitory action on the GI system. So what does sympathetic nervous system do? It has to inhibit the GI system. So what does it do? It will decrease gastric secretion. Okay, it will decrease the motility, to reduce the peristalsis, and it will cause constriction of the sphincter, and the blood vessels. This is what sympathetic nervous system does to the GI system. Sympathetic nervous system slows down the GI activity, and parasympathetic nervous system speeds up. So what does parasympathetic do? It increases peristalsis, it increases gastric secretion, and it relaxes the sphincter. Sphincter open avvali kada. If the sphincter has to open, it has to relax. That is done by parasympathetic. The GI system has its own nerve supply called enteric nervous system. GI system is the boss. Okay, 30 feet. So it wants its own things, it wants its own comforts. So it has its own enteric nervous system. It is also called as intrinsic nervous system. It's special. Myenteric plexus, I told you. Myenteric ante, it is present between the longitudinal and the circular, between two muscle layers. It controls the GI movement, and submucosal plexus untai kada. Whichever is below the mucosa, you remember that mucosa, mucus secretion, okay, like that you remember. So any kind of submucosal, that is Meissner's, okay, that is required for secretion, control of secretion and local blood flow. But whichever is between the muscle is required for peristaltic movements. So myenteric is meant for the peristaltic movements, and Meissner's are meant for control of the secretions. Okay. Next, enteric nervous system is one of the main divisions of autonomic nervous system. So enteric nervous system, ekkadi nunchi vastundi, from where is it coming? It's coming from autonomic nervous system. It's also known as the second brain. Obviously, 30 feet long, wants its own nervous supply. This brain is already there, which is not functioning. So we need a second brain, which is there in the GI system. That is working very well because we want to eat all the time. All of us are big foodies. Enteric nervous system communicates with the CNS via the vagus. So you need to have some kind of communication between your main system and the autonomic nervous system, right? That is done by your vagus. Vagus is the boss. Okay, it is like a referee. It will try to talk to both the systems. Okay, you guys both relax, try to work in harmony. Is the work of the vagus. Everybody knows what is vagus. Vagus is the 10th cranial nerve. Okay. Digestion process in human. What does a human do? Swallow. You know this part. I told you. Swallowing is a voluntary act. Okay. Defecation. Last part. Sphincter is also a voluntary act. So swallowing is voluntary act. It's controlled by medulla oblongata. Pancreatic secretions have an alkaline. So we just learned that gastric secretions are acidic. Which are the pancreatic secretions? You have also have pancreatic secretions which open into duodenum. So that are alkaline. Their pH is high. Okay. Why? Because they have high bicarbonates. Bicarbonates make the medium alkaline. What is bicarbonate? H2CO3. Bicarbonic acid, or you can just put it as bicarbonate. Okay. This is what which makes the pH of the pancreatic secretions more alkaline. HCl makes the gastric secretions more acidic. Mouth is the first site of the digestion, obviously. I don't, okay, mouth is the first side because you have to chew, all that saliva is excreted. Saliva may you have enzymes which digest a little bit of the food, okay. Three pairs of salivary glands are named. You know you have two parotids, two submaxillary or submandibular. You have two submental or sublingual, okay, which are just below your tongue. Not submental, sorry, sublingual, just below your tongue. Okay, all these things have ducts which open to your oral cavity and they secrete. All that secretions are very rich in enzymes which help in little bit of digestion in the mouth itself. So saliva is secreted in the oral cavity which helps in digestion. Approximately 1.5 liters of saliva is secreted daily. Do you know that? 1.5 liters of saliva is secreted. Parotid, submandibular, sublingual gland are all in pairs. Okay, what is mumps? I told you, na, parotid glands can undergo a viral infection which you see very commonly in babies. It's because of mumps. It's a viral infection caused by paramyxovirus. Submaxillary glands are nothing but submandibular glands. These glands have the longest duct. Okay, all the six glands in the sense, all pairs, three pairs of glands have their own ducts, but the longest duct is the submandibular. Okay, guys, we'll call today. Hmm? Just remember, okay, देखा रास्को वाले क्या 138.26 page number. At least just mention 138 point. Tomorrow you remind me, we'll start from this page. Okay. Ma'am, please use light color pen. Red is not visible. Okay, Dalia, I'll do it. I'll use yellow from tomorrow. Any anti-inflammatory, I just told you, na? Salicylate is being used. Huh? Sulfasalazine. These are all anti-inflammatory drugs for stomatitis. Aarti says hi. Hi to Aarti. Also known as piles. Yes, hemorrhoids are also known as piles. हिंदी में उसको बवासर कहते हैं. तेलुगुलो ఏమంటారు? What do you call piles in Telugu? తెలీదా? వాయిస్ రావడం లేదు. ఓకే. మను Suresh Anna, end చేద్దాం. Thank you so much, guys, for being with me today. Thank you for bearing me for 2 hours. It was like a lullaby for you guys. I hope you all understood today's class. Tomorrow we'll be doing from 138 point. Okay. So I'll see you guys tomorrow. Hopefully we'll have an early class tomorrow between 10 to 12 because I also have one of my main exams, INI-CET, coming. So even I have to prepare. So hopefully we have an early class so that I can sit and prepare for myself. Okay, guys, take care. Bye.